Good afternoon. Welcome to Grand Rounds today. Please remember to sign the attendance record at the back of the auditorium, and also please remember to fill out the program evaluation, and most importantly, give us any ideas you might have in regards to future topics or future speakers. While on that subject, this actually will be the last Grand Rounds for 4 weeks. Bessie Myers is getting an upgrade in its AV system, so when we reconvene on September 18th, it'll be in full Dolby sound and high definition. So today, it's my pleasure to introduce Dr. Carroll. Dr. Carroll is the newest member of the Department of Ophthalmology, having completed her residency at Vanderbilt University. She has very kindly accepted our invitation to give us a general review of ophthalmology, and please join me in welcoming Dr. Carroll.
All right, thank you for the introduction. And so as requested, this will be a review, and so I'm trying to keep it relatively basic. I have no disclosures. So the objectives are to perform the eye exam, the basic eye exam, so you feel comfortable doing that, and then also identify any emergencies, whether that's an eye emergency or a neurologic emergency that can present on the eye exam. And then, of course, identifying those patients who would benefit from a referral to us in the ophthalmology department. So first of all, why do I practice? Well, you only have to hear this once, but a child getting their first pair of glasses, explaining that they didn't know there were leaves on the trees, or a patient after cataract surgery who told me that she could see the flowers outside for the first time in years. She couldn't remember the last time. So ophthalmology is great because we do have the opportunity to kind of make those changes for people and hear those great quotes. So let's start with the basic eye exam. Visual acuity is our vital sign. So when you do have a patient who you'd like to see an ophthalmologist, one thing we would like you to check is the visual acuity in each eye separately. The visual field you complete with counting fingers and confrontation. I recommend that you have the patient cover one eye and stand roughly 1 meter away from them to check. The extraocular movements, you can make an H, or you can make more of a box. And then the pupil exam we'll spend a little bit more time on because that is an area that is challenging. Intraocular pressure is important where it is available. And so in the emergency department setting, there's usually a tonal pen, so we'd recommend you go ahead and use that. The pen light exam should be pretty straightforward. Look at the cornea, look for any abrasions, the conjunctiva, the anterior chamber, and the iris. The red reflex you can look at using the direct ophthalmoscope, and we'll spend a little bit more time discussing the direct ophthalmoscopy as well. So first of all, the pupil exam. Anisocoria is the term for different sized pupils, and we're thinking about pupils that are greater than 1 millimeter in difference. When you do notice this on a patient, the first thing that you want to do is determine which eye is the abnormal eye. You can do this by checking the pupils with the lights down in the exam room, and then putting the lights on full blast, and again checking the pupils. The difference will be greater with either the lights down or the lights up. If the difference is greater when the lights are on full blast, then you think that the larger pupil is probably abnormal because it failed to constrict adequately. The reverse of that is when the smaller pupil is abnormal, and that would be with a greater difference with the lights off. And so you can always think that through instead of memorizing it. It's a little bit easier. The differential diagnosis of an abnormally dilated pupil includes a cranial nerve 3 palsy or herniation of the uncus. These are both life-threatening, so it's something that we don't want to miss. It can also be due to surgery or trauma, which is usually obvious from the patient's history. It can be pharmacologic. For example, if a patient had contact with a scopolamine patch or something that's called an 80s pupil. If the small pupil is abnormal, the number one thing we don't want to miss would be a Horner syndrome, because a Horner syndrome could be caused by something like a carotid dissection or a mass of the lung apices. Horner syndrome meiosis is associated with anhidrosis, which is a lack of sweating on that side of the face, and also ptosis. The ptosis that we see with Horner syndrome is mild. It's not the same as a cranial nerve 3 ptosis. And so I recommend actually measuring the distance between the eyelids on both eyes, because the difference is usually only about 1 millimeter. difference in the Horner syndrome. Another reason for a small pupil can be scarring after inflammation or surgery, a pharmacologic cause such as the patient using pilocarpine, or something that's called an old 80s pupil. Moving on to direct ophthalmoscopy. This is a skill that does take practice to feel confident at doing during the exam. So I recommend, first of all, just turn off the room lights. That allows the patient to have the most dilated possible pupil. And have the patient look in the distance. If they're looking at you, then the pupil will also get smaller due to accommodation. Approach the patient about 15 degrees from center, because the optic nerve is about 15 degrees off center. And then because direct ophthalmoscopy has such large magnification but a small field of view, it can be difficult to find the optic nerve. And so I recommend that you find a vessel and then move along the vessel until you find the optic nerve. All the vessels should eventually lead to the optic nerve. Things you can look for when you're doing this part of the exam is a large or abnormal cup in the optic disc. And so I have a drawing here, and it demonstrates a normal optic disc cup. The largest area of the cup in a normal disc is inferior, then superior, then nasal, and then temporal. And I can remember that because it's the isn't rule: inferior, superior, nasal, and temporal. You can also look for plaques in blood vessels or any hemorrhages, as those would never be normal. And those patients would all benefit from a consult to ophthalmology. And so here's a picture of our direct ophthalmoscope. The other thing you can do is hold it up to your eye, stand back a couple of meters from the patient, and look at both of their eyes at once through the ophthalmoscope to look for the red reflex. That could be abnormal or different between the two eyes if the patient has something like a cataract, a retinal detachment, strabismus, which is misalignment of the eyes, or an intraocular tumor. So it's definitely something that we wouldn't want to miss. Most of the ophthalmoscopes also have a blue filter, and you can turn this and use that to look for a corneal abrasion in a patient where you're using a fluorescein strip anyway. So eye emergencies are anything where the patient presents with sudden vision loss, an open globe or trauma, severe pain that doesn't get better with a drop of proparacaine, like scleritis, chemical burn. We would gather that from the history usually, or acute angle closure glaucoma. Now, many neurologic emergencies may also present with eye findings. This is because cranial nerves 3, 4, and 6 control the extraocular movements. And so we'll go over those briefly. Other findings are stroke, a brain mass, demyelination such as in multiple sclerosis, or intracranial hypertension. These patients can all present with a visual loss or a cranial nerve palsy, and they all require imaging. So we'll start with the cranial nerve 3. This is the oculomotor nerve. A patient who has a cranial nerve 3 palsy will present with one eye looking down and out, and also with ptosis of the eyelid. Now, when you lift that eyelid up, if the pupil is also large, that's a pupil involving cranial nerve 3 palsy. That's very concerning for a possible aneurysm in the brain. And so this patient requires emergent imaging. A trochlear nerve palsy is a fourth nerve palsy. These patients may present with oblique double vision, meaning that the double images are not just side by side or just up and down, but they're off to the side, side by side and up and down. These patients may have diabetes or hypertension, and they may present with a head tilt to try to make the images become more aligned. And so I would also recommend imaging in these cases. A sixth nerve palsy is known as an Abducens nerve palsy. And I think this picture demonstrates well that although sometimes patients come in and they have an obvious esotropia, meaning the eyes are crossing in the center, sometimes the central gaze does not have a large esotropia that's apparent. However, when you have the patient follow your finger looking around the room, you'll notice that one eye struggles to abduct fully or look out away from the patient. In this case, it's on the left eye in this patient. And so in these cases, once again, we think about imaging, and with all cranial nerve palsies, in older patients, we think about giant cell arteritis, as this could also cause a cranial palsy. And so we also ask them some questions about weight loss, fevers, or polymyalgia rheumatica. We consider testing the ESR and CRP with the CBC. Additional neurologic emergencies would include a stroke, a patient coming in with a new visual field defect, cranial nerve palsy, or other signs of a stroke like confusion, ataxia, hemiplegia, or aphasia. And so these patients will need imaging in the stroke protocol through the emergency department. People with a brain mass may have a slow onset of visual symptoms. Sometimes it's difficult for them to describe what's wrong with their vision, and that could be because maybe they just have a blind spot enlargement. Other symptoms that they may have a brain mass include pulsatile tinnitus, which is ringing in the ears that sounds like the heartbeat, a transient visual obscuration, or double vision. They require an optic disc exam and imaging to identify a mass. This is something that we might see in one of those patients. This optic nerve is abnormally elevated. It has edema. This is seen when patients have elevated intracranial pressure or intracranial hypertension. They have the same symptoms as patients that have a brain mass. In addition to imaging, I would recommend a lumbar puncture with CSF studies. The CSF studies allow us to rule out things like an infection causing meningitis, and also to gather the opening pressure to determine if there truly is elevated intracranial pressure. If there's no infection and no mass, then there's a term for this. It's idiopathic intracranial hypertension, or IIH. One of the older terminologies for this disease is pseudotumor cerebri, and so you may hear that as well. Patients with multiple sclerosis or other causes of demyelination frequently present with optic neuritis as their first symptom of multiple sclerosis. They'll have decreased vision in one eye, they can have decreased color vision, and most have pain with eye movements. They also have a relative afferent pupillary defect, which we'll talk more about shortly. Other signs of multiple sclerosis or stroke could include an intranuclear ophthalmoplegia, which is slowed adduction of one eye with a contralateral nystagmus. So a relative afferent pupillary defect is something that you should be able to pick up on the pupil exam. The key here is the pupils do look the same in light and in dark. You only identify a problem when you swing that flashlight back and forth between the two eyes. I looked for a video, but was not able to find a great video of this, and so I'll describe it the best that I can. If this patient had a left relative afferent pupillary defect, when I shine the light in the right eye, both pupils would constrict the same amount. When I shine the light in the left eye, they would again constrict the same amount. But then when I move the light from the left eye to the right eye, they would both constrict more. And then when you move the light back to the left eye, they both dilate a little bit. And that's because that left eye is not perceiving the same amount of light as the right eye. And so it would be a left relative afferent pupillary defect. This only occurs when there's a large problem with the visual system, such as an optic nerve problem or a large retinal problem, such as ischemia or retinal detachment. So who should be referred? In children, anyone who fails their vision screening should be referred. For example, if they have an abnormal eye movement or appearance. Here's an example of leukocoria, which is what you would gain by looking at the red reflex. You notice that one eye looks a little bit white and the other eye looks dark. In this case, this patient has a retinoblastoma, and so that is a life-threatening emergency, something that you should refer. For adults, anyone with a vision complaint, whether that's refractive error and they need their glasses or contacts checked, a cataract, dry eye symptoms, if they think they may have glaucoma, a retinal detachment if they have flashes of light or floaters, if they're at risk for retinopathy, neuropathy, or uveitis, which is inflammation inside the eye. Diabetic patients require an annual exam, This is beginning at the onset of diagnosis in type 2 diabetics. People with type 1 diabetes, we do want to start seeing within 5 years of that diagnosis. And anyone with drooping eyelids we'd be happy to see as well. Once again, the obvious referrals are anyone with vision loss, with a painful red eye, or with a history of trauma. So what should a patient who is referred expect when they come to see us? They can expect to have a complete eye exam, complete with a refraction and dilation. Because they're being dilated, they should be told to bring a driver. We'll do additional tests as we need them. So now I'd like to move on to what I consider some of the fun stuff, and this is a review of some of the advances in ophthalmology. Ophthalmology has a lot of research currently, and I think that's because people value their vision so much. And so there are advances in imaging, medicine, gene therapy, and surgery, but I'm going to focus on surgery, specifically cataract surgery. The first cataract surgery recorded occurred in about 800 BC in India. These patients had a scleral tunnel created, and then when they sneezed, the cataract was expelled. We had to step backwards with couching in the 18th and 19th century, and this is recorded in Rome. Patients who underwent couching did not expel their cataract. The cataract was instead just pushed to the back of the eye into the vitreous cavity, and so immediately the patient would notice that they could see more light. These are patients who are probably nearly blind from the cataract. But within a couple of weeks to months, they would most likely lose vision and have severe pain while losing vision. And that's due to the inflammatory reaction created to the lens in the wrong part of the eye. Fortunately, the medicine people in the 18th and 19th century were moving around and would have already left before the patient lost their vision. This still occurs occasionally in undeveloped areas. We moved on to what's known as intracapsular cataract surgery, meaning the outermost layer of the cataract was kept intact and the entire cataract was removed. Well, the cataract is the lens, and the lens is held in place by zonules, and so those zonules had to be broken to remove the cataract in this fashion. This required a very large incision to be made on the cornea, and because the backside of the capsule is removed as well, there could be traction on the vitreous, because the vitreous, that jelly inside the eye, does have connections to the back of that lens capsule. Vitreous traction is concerning because it increases the risk of the retina being pulled away from the back of the eye, causing a retinal detachment. And so results of intracapsular cataract surgery are not great. Fortunately, extracapsular cataract surgery was the next advancement, and that involved leaving that capsule in place on the backside of the lens. But this still required a very large incision to be made on the eye, which creates a lot of corneal astigmatism. In order to complete these surgeries, many patients would require a retrobulbar anesthesia, which is what's demonstrated in this picture. We use a needle to place lidocaine behind the eye. As you can imagine, there are potential risks, including damage to the optic nerve or even damage to the globe. Now, topical anesthesia is what I practice most frequently, and that involves just using a lidocaine gel or proparacaine drop on the surface of the eye, and then asking the patient to hold still. Of course, we do have help from our anesthesia colleagues in keeping them still as well. General anesthesia we use only rarely in a patient with a head tremor or a patient with dementia. So here's a video of extracapsular cataract surgery so I can better explain. This is from iRounds, which is a fantastic resource for education available through the University of Iowa. And this video is circa 1987. And so you can see that a peritome was already created, removing that conjunctiva in the area where this large incision is going to be made to remove the cataract. The incision is being made, and now the capsule, the front part of the lens, is getting its capsular rhexis by what was called a can opener technique. Now the lens is being rocked to try to free it from the capsule so that it can be removed in one large piece. This next step, the incision is further enlarged. A safety suture is placed because there is a risk of hemorrhage within the eye due to the large change in intraocular pressure you're going to see here as the lens is expelled with pressure externally. It's very impressive to see that lens come out all in one piece. Additional sutures are being placed, and then the cortical material that surrounds that hard nucleus of the lens is being removed. And they're preparing to be able to place an implant. They're polishing the lens capsule. And because they have sutures in the way, they have to loosen them to allow there to be space to place this large implant. This implant is similar to some of the implants available now, although it's fallen out of fashion, so to speak, and that is due to this implant has a few spots to hold on to, those hooks there, and those can sometimes cause some optical aberrations. It's a 3-piece lens implant, and so that means that it can be placed either within the capsular bag or within the sulcus, which is in front of the capsular bag but behind the iris. So now you can see the excessive amount of suturing required to close such a large incision. You can understand why postoperative astigmatism can be such a problem in these cases. Fortunately, phacoemulsification, which is now the standard that we use here, was invented back in 1967. It didn't become commonplace and probably until the 1980s, but it offers several advantages. So phacoemulsification is the use of ultrasound energy to break the lens up into many small pieces, which then can be removed with aspiration from the eye. And so the wound created is much smaller, as we'll see in our next video. And so there's less postoperative astigmatism and better refractive outcomes. So this is a video from our operating room, and I'll apologize in advance that it's a bit choppy. We're working on getting the right writing speed for our video equipment. And so you can see here that I am creating an anterior capsular tear to create a circular opening through which we're going to be able to get that cataract out. So this is an advancement from the capsular tear used in the last video, and that's because I was able to keep this nice and round. That reduces the risk that as I'm pushing on the lens later, that the tear extends around the back side of the lens. You want to avoid that because then the lens would have nothing keeping it from falling into the back of the eye. So while this step is relatively short, it's of utmost importance to the surgery. And so now I've hydrated the lens and I'm getting ready to use phacoemulsification. This is that phacoemulsification needle that uses ultrasound energy to break up the lens further. You can see here I'm sculpting a groove across that cataract. And that will allow me to break the cataract up into more pieces. And my second instrument here using to break that cataract into 2 large pieces. We'll rotate it around a bit, sorry about the jumpiness, and start removing the chunks of cataract with phacoemulsification and aspiration. I like to feed the pieces directly into my phacoemulsification needle so I can reduce any risks. So now most of the nucleus has been removed. And you'll see the remaining material is cortical. I use a bimanual technique in order to remove this cortical material. And so at this point in my right hand, I'm holding my irrigation system, which keeps the eye nicely formed. My left hand has the vacuum piece, which is pulling on that cortical material, loosening it from the capsular bag. You'll see it comes off in nice large pieces. And since I am doing this bimanually, soon you'll see me switch hands so I can do the other side of the capsular bag. Sorry about the jumpiness, we're working on that. Let's say that the actual hand movements are quite fine. So now we're doing the other side of the cortex removal. And we'll polish that capsule. Get any final pieces of cortex out. And now all that's left is putting the implant in and closing up the incisions. This is me placing some jelly to keep that potential space open to put the implant in. Here goes the implant. You can see it's folded up so it can fit into that small incision. Now it's unfolding into the proper plane. I'm centering it. Now I go ahead and close the incisions using just saline and get that remaining jelly out. And that's the end of the case. So, one of the important things that we've had a great advancement in is that implant that we put in at the end of surgery. And that's because more and more cataract surgery is becoming similar to refractive surgery, where I can really reduce the need for glasses after the case. The first implant was placed in the 1950s. In 1949, a World War II pilot had his windshield explode into his face, and some of the material remained in his eye and did not create an inflammatory reaction. And so an ophthalmologist said, well, maybe that would be a good material to use for an implant. Prior to this, patients who had cataract surgery were left without a lens or implant, and that created about a +20 diopter refractive error. That's something where even with a Coke bottle glasses, it would still have a limitation in vision to about the 20/70 line due to the optical aberrations from such a large lens. And so that first lens was placed in 1951, and it was based on an anatomical model of the eye. Unfortunately, the refractive indices of the different materials within the eye were not taken into account. And so the first implant resulted in a -20 diopter refractive error. And so it was no better than not having an implant. And so I showed a drawing where you think about going spear fishing on your Saturday afternoon, like most of us do. You'd want to throw that spear in front of where you see the fish. And that's because as the air hits the water, the light is moving from something with a smaller to greater refractive index, and that causes the light to bend. And so that had to be taken into account with a multitude of other factors. And so currently I use multiple calculations to compare using statistical regression, ray tracing, and divergence formulas to determine which implant to place after cataract surgery in a patient. The variables that we take into account are different measurements of the eye. The axial length and the corneal power are some of the most important measurements, but some of our calculations do take into account where we think that implant will sit within the eye based on the other measurements of the eye. There are many potential sources of error, such as variability between the formulas, variability between surgeons, but overall, more than 95% of our patients are within 1 diopter of their predicted refraction. So we can minimize the need for glasses at 1 distance pretty well after surgery. But as many of us learn over time, presbyopia sets in, and that means we can't read up close without glasses. Well, that's because the natural lens cannot be molded or changed in shape as much as we have more birthdays. And when I am replacing the lens with a piece of silicone or acrylic, that lens usually does not change shape either. And so that means that I can only correct the vision at 1 distance, unless I use a multifocal implant. And these are being used with a lot of success around the country, and they allow a patient to have good vision at multiple distances, although we never make guarantees. And some of the advances in the implants are because, as you saw in the video, they fold, and so we can reduce the amount of astigmatism. If someone has astigmatism, we do have options to correct astigmatism as well at the time of surgery. So that's an exciting area of research that's allowing us to have those improved refractive outcomes, and that's in part due to our measurements becoming more accurate. The calculations for the implants are also becoming more accurate, and we have more options to compare against each other. And then the intraocular lenses themselves are an area of active research. Currently, there's an intraocular lens that can be adjusted in power using a laser, and that is something that's on the horizon, not available yet, but something that we look forward to in order to help patients who maybe ended up a little bit off the refractive goal. Other advances in medicine have also affected ophthalmology. For example, one thing I do like to mention when I have a group of providers is that alpha antagonists can lead to something called intraoperative floppy iris syndrome, or IFIS. And this is something that we can see in patients who have only had 1 dose in their entire lifetime. And what can happen is they can have meiosis, which is the pupil getting small during the surgery. They can have billowing of the iris and poor stability in general of the anterior chamber and capsular bag. We can also see prolapse of the iris, meaning the iris can leave the eye through one of those small wounds during the surgery. Now, as you can imagine, that can have some poor outcomes in terms of the iris anatomy and also increase the risk of the surgery, increase the risk of infection, increase the risk of retinal detachment. So, although there are many alpha antagonists, the most frequently used alpha antagonist is called tamsulosin, and I would urge you to consider whether cataract surgery referral is indicated prior to starting tamsulosin or Flomax. Something else that ophthalmologists in general like to touch on, and I'd like to speak about now, are steroid use. We do have good evidence that steroids increase eye pressure. Increased eye pressure can lead to glaucoma. Glaucoma can lead to vision loss, first peripheral vision loss, and eventually central vision loss in severe cases. Steroids can also worsen cataract, and they can worsen infections such as herpes. And these complications can all lead to vision loss. So my take-home points today are that you should be practicing that pupil exam and the fundus exam in all of your patients to help identify any abnormalities for referral. If you're struggling a lot on a patient, that might be a good one to refer because they might have a medial opacity or other cause of difficulty with the exam. Neurologic emergencies may present with visual complaints, so we need to remember stroke, multiple sclerosis, and idiopathic intracranial hypertension in the appropriate populations on our differential diagnosis. I'd be happy to see patients with a failed vision screening, vision or eyelid complaints, or diabetes. And the treatments for blinding conditions are rapidly advancing. I didn't have time to touch on some of those treatments, but it is pretty exciting. And when you're seeing a patient who might require tamsulosin, we'd recommend considering whether a cataract surgery referral is indicated prior to starting that medication. So now I have time for any questions.
Thanks for letting us know about the alpha antagonists. I presume tamsulosin is the most risky, but are the others also pretty risky?
Yes, like doxazosin, for example, is the other one that I see more frequently, but it includes all of those alpha antagonists.
Question. What are the likely complications of current state-of-the-art cataract surgery, and what is the percentage that one might expect?
All right, so the percentage of complications is, I would say, 1 to 2%. Most frequent complications would include postoperative increase in eye pressure or inflammation. And these are pretty rare, and they can be treated usually with eye drops postoperatively. Other more concerning but less frequent complications would include endophthalmitis. I think that depending on the study that you look at, that complication we're looking at somewhere in the 1 in every several thousand patients who have cataract surgery. And other complications would include poor refractive outcome, if you count that, which we do, or a retinal detachment. That's more likely in patients where that posterior capsule is ruptured. All of these complications are more likely in those cases that have intraoperative complications.
Hi, I have a question on just in terms of circulation for the eye. This issue comes up quite often. Is there anything magical that you have to offer in terms of evaluating the ophthalmic artery or getting a better handle on the anterior ischemic optic neuropathy?
I would.
It's still pretty much just a clinical kind of thing, and there's no imaging or studies that you can do in the office that will give us a better answer.
Well, we do have some studies that can show us the flow of blood kind of right at the anterior-most portion of the optic disc. We could do a fluorescein angiogram, or more recently, we have a machine, oculocoherence tomography, with an angiography component. And so we can actually see the blood flow to through the choroid to the macula and to the optic disc, but we can't see posterior to that. Where you might have someone with a posterior ischemic optic neuropathy, that diagnosis is still one that we are always very careful to make.
Yes. As a non-ophthalmologist, if people have had radial keratotomies, does that significantly affect the calculations as far as the lens power or how close you can approximate an intraocular lens that you're going to put in, and are they making advances to compensate for prior surgeries?
Yeah, so I can actually answer that question and a similar question, which is about LASIK. In both cases, when the corneal topography has been altered, the lens implants don't necessarily act the way that we would expect them to. In radial care and RK, usually the implant is pretty similar to what we would choose. We do expect there to be prolonged corneal edema following cases where the patient has had RK and a risk of having some hyperopia. And so in patients who have had RK, I do recommend that we aim for a little bit of nearsightedness and also understand that the recovery will probably be much longer than your neighbor's recovery after their cataract surgery. There's always a small risk of one of those incisions popping open during the surgery as well. If that were to happen, we could have some additional stigmatism from having to suture those back together. Now with LASIK, we are developing additional measurements and then also doing additional calculations to determine kind of our best fit for which implant we think will work the best. I'm always very careful preoperatively counseling patients who have had LASIK because we know that there's more room for error since that corneal asphericity or Q value has been altered. Especially in patients who are interested in a multifocal lens, that's something that I wouldn't recommend after LASIK, and that's because both of those can create kind of higher order aberrations, which can be very bothersome to people and hard to describe.
So I went to a lecture one time on how many physicians, particularly emergency department physicians, actually got a good look at the fundus, got a good look at the optic disc, and just like you said, you got to find the vessel and find your way toward that. But we do know that a lot of primary care physicians and emergency department physicians really have a hard time seeing the disc. And so, since the pupils are not dilated, they're really tiny in a lot of people. So it's a challenge nationwide. And I had heard that there was the potential for some technology, a camera or something that could actually not use a human, but could actually be used to see if there was an elevation of the disc or some other abnormalities. Do you know, are those cameras or those technologies anyway to look at the fundus? Do you know, are they widespread or is it too expensive for us to get one here?
I do know that there are some startups that are trying to create some fundus cameras that you can connect to your smartphone, for example. Usually these are for ophthalmologists who are already using a lens and already have the eyes dilated. And so in terms of looking through a small pupil, let's say there is retinal screening that takes place in some locations with a camera without dilating the pupil. And so I know there is technology available. I'm not sure how much it costs or how accurate that would be. The other issue we run into is, I guess, false positives, but also false negatives in people who have only a small amount of disc edema. And that's because without a stereoscopic view, that could easily be missed. I would recommend, if you are shopping for an ophthalmoscope, to consider one that is the slightly more expensive version that has that longer extension that you actually place at the patient's brow. That seems to be a little bit easier because you're not trying to figure out where to hold the ophthalmoscope. If you're practicing and haven't practiced in a while, right, right, right. So right hand, right eye, patient's right eye, left, 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 so you're not kissing the patient. All right, well, thank you.